Flexion and extension, yeah, tibial rotation a bit. We'll test that with the McMurray's for meniscus. Do we do active or passive first?
Active.
Active one.
See what? Yeah.
Yeah, so she's in control of the movements, any pain, she's going to prevent that and restrict it herself. Let's look at flexion first. So if you bring both of your heels to your bum for me, please. So bend the knees, heels to bum, note the towel placement, please. We want to see towel technique and everything today. We can have a look at toe position just to see if there's any obvious imbalance there. I can tell you that there's not really. And we can have a look at knee height as well. Again, towel in place, make sure of it, just to see if those knees are fairly level. They are. Legs back down.
Could you also look with that one whether the knees sounds slightly going apart?
Yeah.
Yeah.
Yeah, you could see if there's any of that internal rotation coming from the hips or anything like that. Knee extension, I'm going to be in your way for this, but the main one's the right one, so don't worry about moving or anything. I'm going to pop my knee under there, so she's got somewhere to extend from. Extend your knee, straighten your leg out, please. Good, and back down. So that's all fine. Any pain there at all?
No, nothing.
Good, all feeling okay. That's how the left leg moves. Maybe you want to go on to passive straight from there as well, but we'll just keep it active for now. We've looked at flexion, let's look at extension. I want you to squeeze the quadriceps, extend the knee for me, straighten the leg. Good, and I'm feeling for that activation there just to make sure that we've got contraction, vastus medialis, lateralis, everything else. Any pain there?
Okay.
Good, okay, everything fine. Active's fine, so we can go ahead with passive. And she's got instability, so we're thinking specifically about the ligaments there. So let's have a look at that. Movements available at the knee, one more time, in chorus.
Flexion, extension.
Flexion, extension, yeah, we'll go with that for now. Flexion, pretend I've done this leg, because I don't want to get in your way and just waste time, but we're going to have a look. Let's imagine she had no pain on passive on this side. So let's have a look at full flexion, and take your time with it. Have a look for the end feel, make sure it's a bit of a bounce back there, and it's not a bony end feel. How does that feel, Sharon?
That's okay.
Yep. And then into extension. Knee there again, relax. Make sure you're securing above the patella. And extend. Any pain?
Okay.
Good. Difficult to measure, so we can get that on the couch then as well, and we can just have a feel for does that heel lift up off the couch. Usually we're looking for about 5 degrees extension. What that means in reality is that this heel should lift up a little bit. Should be no pain. Good. All feel all right, you're going to listen.
Yeah.
The knee joint itself, let's have a look at the patella as well. As instability, we want to make sure that there's no wear and tear on the back of the patella. We can use Clark's sign for that if you can remember, which is just a little push down into the kneecap. Move from side to side to see if there's any wear and tear on the back of the patella. Slowly contract your quads on the left side. Good, that's going to pull the patella even further, and then relax. That was all okay. And then we'll do the same on this side. Have a look for patella mobility. Push in with a bit more caution here, because this is the bad side. Little move from side to side, and slowly tense the quads. And relax. All good?
All good.
Good.
If your client is older, chances are when you do that, you are going to find something. You know, there's going to be some arthritis or some cartilage damage, etc. But that doesn't mean it's the whole story. So
no, because you're always comparing one side to the other.
Yeah. Okay.
Yeah. If it happened this side, that's almost baseline. You can almost expect it for this side.
Okay.
Yeah. Good question. Onto ligaments. This is the bit we're going to fly through a little bit, so don't be overwhelmed. We're going to assess MCL and LCL. They're the big ones for me because we've got instability. So we have a look at that side. We know what her knee looks like. Is she hypermobile? Is she fairly restricted? I would say from experience, pretty middle of the road, I think, Shannon. So having a look at this, I'm not getting closer for this. Having a look at this valgus force through the knee. So no instability there and no pain. Good. Having a look at LCL. We can do that a couple of ways. We can just do a bit of tibial rotation and also put some varus force through the knee. All good?
All good, yeah.
Other ligaments of the knee to test? ACL and PCL, yep, so we can have a quick look at that. You can all see better than I can from there. Anterior draw, what's happening? Nothing much. PCL, nothing much. Last one then, McMurray's. Palpate the joint line and rotate all the way down into flexion. Practice this one because a lot of people get this one wrong. We're looking for tibial rotation with a bit of flexion. And that feels okay.
Yeah, all good.
I want you to bring your leg up to about there. Good. Match my pressure for 3 seconds. I'm going to slowly increase the pressure that I put through. Go. 3, 2, 1, and relax. Good. All good.
All good.
We've assessed that compared to this side as well, so you know I felt the same. And then knee flexion. I want you to pull your heel into your bum. I'm going to resist you here, match your pressure.
Yeah.
Ready, go. 3, 2, 1, and relax. All good.
All good.
Good. It's all good, which means we can move on to hip assessment. You're with me so far?
Yeah.
I don't want to run away with it. Good, okay. Hip assessment then. I've seen you doing hip assessment in standing, which I think is great because you're doing the active, you're doing flexion, abduction, extension, rotation, which is great. Practical exam, fantastic, do it. In reality, my preferred approach, which is not necessarily the correct way, it's just how I prefer to do things, is to get everything done on the couch. So I'm trying to do everything that I can in supine, and then sideline, and then prone. So I'll begin with active assessments in supine. If we're working against gravity, which hip movement can we get there in supine?
Flexion.
Flexion, yeah, because we're working against gravity. So on a side, it's going to be abduction, and prone is going to be extension. So lift up this leg for me, just about my hand here. Good, and then back down. She'd let me know there's any pain by this point, she's sick of me asking. Lift up this hand, leg, and back down. I know what I'm doing, honest. Okay, that felt fine, so we can do a bit of resistance test now. We will assess this one. So leg up, match my pressure. 3, 2, 1, and leg down. I want to make it difficult for her, but also there's been some hip impingement, so I'm kind of somewhere in between. Any pain?
No pain.
Okay, but there was, we need to keep that in mind. Lift up here, match my pressure. 3, 2, 1, leg down. I didn't feel any difference, did you?
No.
Yeah, all good. Let's go with the passive assessment then, because we're in supine. So we'll have a look at hamstrings. Pretty good. Yeah. We'll have a look at hip flexion. Being careful in that deep position. You let me know if there's any twinge. We don't want to set it off.
A little bit in there.
Okay, we're not going to go too far. We'll keep that on the side. Rotation. External. This is the one that's going to trigger off hip impingement, so just go steady. Any imbalances there, do you think, between external and internal rotation? Is that a lot of internal rotation?
It is a lot, yeah.
There's a lot of internal rotation. So muscularly, what am I thinking might be tight, what might be weak?
Internal rotators tight.
Yep. External rotators possibly a bit lax, not controlling things. So there's another check in that box. We're heading down that road quite successfully at the moment, lacking a bit of external rotation, which tells us maybe the internal rotators are tight and restricting things. A bit of abduction, passive abduction to test the adductors, but again this might trigger off that hip impingement pain, so we're not going to go too far.
It's okay so far.
Good, I'm not going to push that one too hard, and then we're going to go for adduction to have a look at the abductors. If the internal rotators are tight, internal rotators being TFL and glute med, what can we expect to see here when we do this? A little bit of restriction, yeah, so we're hoping for it, because it'll help with our clinical reasoning. Relax. Anything there at all?
That's all okay.
Okay. Bit of stretch.
Yeah.
Where did you feel it?
Up in here.
Okay. Go on your side facing that way. In the interest of time, we're just going straight onto the right hand side. So legs out straight. We want to assess these muscles here now because we're quite interested in what's happening with TFL and glute med and how that all relates to the rest of the hip. At the moment, just a little pit stop for you of where are we with this. My working conclusion is that Shannon's knee instability is coming from overactive internal rotators and underactive external rotators, allowing the knee to drop in. So at the moment, you're kind of trying to disprove that theory a bit, I guess. So let's have a look at abduction then, seeing what's going on with these. Lift up the leg for me, and back down. Lift up into my hand and match my pressure for 3 seconds. 3, 2, 1, and down.
No pain, but it's really tight in there.
In
Just general area all the way up here.
along here,
Yeah.
okay. It's quite a vague response, but it's useful because you might want to then test the other side to see how that feels. Something else that we can do here though is to find if any muscles are cheating. And Shannon mentioned something about QL earlier on. So what we'll do, as Shannon abducts, we'll palpate QL because we want to see if this isn't working, if there's any dysfunction inhibition here, is anything else compensating for that? And a common compensation pattern is QL. So instead of allowing hip abduction, hitches the hip. So So let's put the thumb in there and lift the leg and down. Okay, so there's definitely a bit of activation there in QL. I would encourage you to try that on lots of different people, because you'll soon know when somebody's got an overactive QL. You'll feel that, just like in the glute firing test, where the hamstrings initiate the movement. The same thing here, QL initiates the movement. So I'd say there's a bit of an overactive QL, a little bit of weakness here as well, possibly these, but we'll get onto that. What needs work from me?
Internal rotators and QL.
Internal rotators because they're overactive, and QL because it's also overactive. Okay. Jot this down, not now, but during the treatment if you need to. I'm going to do so now. So we're thinking RX is abbreviation for the treatment, and then rehab, because we need some clear plan for Shannon when she leaves. So at the moment we've got QL, glute med, we'll just say piriformis. And there was a little bit of weakness there in abduction, a little bit of shaky instability as well. So we're going to say glute med, even though they occupy both columns, that's fine. Relax this top leg, support the lumbar spine, and see is there any pain, is there any restriction. Just lower that leg down, just relax, let go of any tension there. Bit tight. It's not quite dropping down to the couch. So backs up our theory, this needs some work. And come back.
Question.
Yeah.
If they're shorter, they've literally got a shorter femur. Is that going to affect that overstep? Because if I've got someone who's like 6'7", they've got a giant femur, they could basically appear like T-band is actually fine.
Yep. That's good. Internal rotation. That's our end of range. What do you reckon? Tight, lax?
A bit tight.
A little bit tight, yeah. Might just be Shannon. We'll assess that compared to this side. Internal rotation?
Very tight.
Quite a lot. And I'd say even more significant when you look at the lack of external rotation. Again, backs up the theory. Maybe we've got some laxity in piriformis allowing internal rotation, tightness in glute med TFL preventing external rotation. Hip extension feels good to me. And then we can have a look at glute firing as well. So 2 fingers in the erectors, one in the glute, another in the glute, another in the hamstring. Lift up your left leg in a straight line off the couch, please. Good, and back down. Can't fold that, absolutely fine. To flesh that one out, I felt glute activate first, and then a bit of erectors, a bit of hamstring about the same time. As long as glutes go first, that's the main thing. Right side, is it going to be tight?
Not bad.
No, pretty good. Rotation.
Tight.
Yeah, and there's a difference there again, which is nice for us to see as a therapist looking for a pleasing outcome to validate our suspicions. And then internal rotation.
Lax.
Again, pretty lax, but actually there's not much difference side to side there really, I don't think. So a lot of the rehab that we ask her to do can be applied to both sides, maybe with a focus on the right. Passive hip extension. I know you can't see what I'm doing. And I want you to repeat this leg lift on the left side. Go, and back down, and relax. Go again. Good. Glutes doing their thing. I think Shan kind of knows what I'm looking for as well, which does influence the test. So try not to let them know beforehand what they're doing. So there's our basement for a treatment, I think. We don't need to continue on assessing ankle, trying to completely exhaust the assessment process, because we've got enough now to go on, to work into, and then to reassess, because it's the reassessment that is potentially the most important thing at the end of a session and at the beginning of the next. Because otherwise, it's the definition of insanity, doing the same thing over and over again with no clear reasoning for it. There's one last thing that we're going to look at here, and that's, we noticed that there was an overactive QL on the right side, which is something I've seen before, so we kind of fast forwarded to that. But this isn't working, something's going to be compensating for it. It's coming from above the hip. So let's have a look at the PSIS. So this comes into the postural assessment side of things, which we skipped over, but I may do, and at this point I'll definitely have a look. And what we can see, even in prone, when you palpate the PSIS, is that the right side is slightly elevated above the left.